Welcome to the Dental Code Advisor podcast, brought to you by Practice Booster. I'm your host, Dr. Greg Grobmeyer. Practice Booster is the dental industry's trusted source for dental coding, administration, medical dental cross-coding, and documentation resources. Practice Booster works hand in hand with the American Dental Association to provide dental practices and their teams with the most current information to maximize legitimate reimbursement and minimize risk. This podcast is for informational purposes only, and the information contained in this podcast has been researched as of the publishing date and is not to be considered legal advice or a guarantee of insurance reimbursement. Now join me and let's get started. Hello and welcome back to another episode of the Dental Code Advisor podcast. I'm Dr. Greg Grobmeyer, your host for today. I am the editor-in-chief of Dr. Charles Blair Practice Booster's Dental Coding with Confidence manual. I'm going to be talking today about the big change that we've seen in SRP claims. I don't know if you guys have noticed it or not, but working with the practices that we do, we've seen a really big uptick in either denials or downgrades for scaling and root planing. And so I'm going to talk a little bit about why we're seeing that and what you can do to hopefully get those claims adjudicated, get them to go through, get them processed, and get those claims paid in a timely manner. We're going to talk a little about documentation. The coding really hasn't changed, but the criteria that payers are looking for kind of has changed. And so we're going to discuss that a little bit in depth today. So thank you for joining me. By the way, if you guys are listening to this on audio, if you are doing a audio podcast format, do know that we do have video available on these now. You can see my face if you want to see my face. I don't know why you would, but there you go. You've got the option of doing so. It's going to have the captions at the bottom and some show notes, other resources that you can touch into as well. Those will be up on YouTube and other video sources, as well as on our website at dentalcoding.com. So do be aware of that, and you're welcome to kind of view it in that format or keep listening. And so we'll go from here. I like to do these in kind of bite-sized chunks on a particular topic. This one today I feel like has particular interest for most practices because most everybody, the general dentists, are doing scaling and root planing within their office. And they are seeing kind of a pushback from payers about when they're going to say a claim is approved. A lot of times I'm also seeing downgrades. I'm seeing people putting in for a 4341 and they end up getting it back as a D4342 instead. And so it gets downgraded because all the sites don't qualify. So we'll talk about what it is, what they're looking for, okay? So in the past, when we were doing scaling and root planing, pretty much if you were sending in all the normal records that you would, you're sending in your radiographs, you're going to send in your probing depths and things like that. If you had, for a while it was 4 millimeter pockets, then it was 5 millimeter pockets kind of being the standard. If you had that and maybe it was showing some calculus, that pretty much was all you needed to get an SRP claim adjudicated, and it would go through and get paid and things were good. Okay. It's kind of not the case anymore. We are now dealing in a world where most of the payers, in fact, about 85% or even possibly more at this point, payers out there are using artificial intelligence. They are using AI to do measurements on your radiographs. And so that has some specific implications. I want to talk about what criteria they're looking for and all of that as we go through. So it's less these days about pocket depths. That's the big thing. That's the big takeaway I want you to have. You can have pocket depths that are purely due to inflammation. And so I can have a 5 millimeter, 6 millimeter, 7 millimeter pocket with absolutely no bone loss. Okay. Bone loss is the requirement for periodontal disease. And so I want to read the actual code language on a D4341. So this would be very similar to what the D4342 is as well. It's periodontal scaling and root planing, 4 or more teeth per quadrant. Well, that's what most everybody sees when they look at their practice management software, right? You've got the nomenclature and the code number, which is the D4341. That's what I've given you. What you don't see is the descriptor that the ADA gives you in the CDT manual. It's also in our Dental Coding with Confidence book. And so here is the descriptor, and I want you to listen to the verbiage here and make sure that you're picking up on everything that it's saying. It says, this procedure involves instrumentation of the crown and root surfaces of the teeth to remove plaque and calculus from these surfaces. It is indicated for patients with periodontal disease and is therapeutic, not prophylactic in nature. Root planing is the definitive procedure designed for the removal of cementum and dentin that is rough and or permeated by calculus or contaminated with toxins or microorganisms. Some soft tissue removal occurs. Okay, that's important. This procedure may be used as a definitive treatment in some stages of periodontal disease and or as a part of pre-surgical procedures in others. And so that is the full descriptor. There's some components there that payers have really latched onto. And all these little bits and pieces that are in these descriptors of these codes that generally you guys are not seeing, that's all criteria that has to be met in order to say that you legally and completely delivered this procedure. Those things really ought to also get notated in the clinical chart. So some soft tissue removal occurs. Okay, make a note about that when you're doing your clinical notes, because that's a required criteria or required component of SRP. And so with that, the point is that it has to be where you are removing plaque and calculus from both the crown and root surfaces of the tooth. So for the root surface of the tooth to be accessible, there has to be some clinical attachment loss. And so, whereas you can have a 4, 5, 6 millimeter pocket, like I said, just from inflammation, from swelling, that means the gums are going up, even though the bone level remains where it normally is. So that can be gingivitis. That could maybe fall under a 43, 46 case, but not D43, 41 if there is no bone loss. There has to be bone loss present, clinical attachment loss, in order for periodontal disease to truly be there. Okay? And so with that, dental payers are really requesting that you send in radiographs that demonstrate this loss of bone. The first thing that they're looking at these days is not the pocket depths. It's, is there clinical attachment loss, bone loss, visible on the radiographs? Normally they're looking at the bite wings. Okay, they're looking at your bite wing radiographs. And so it's absolutely critical that those bite wings are of diagnostic quality. They're using AI, like I said. They're using Pearl, Overjet, Vidya Health, one of these major players. They're out there doing measurements. They're checking, they're looking at the CEJ on the tooth, and then they're measuring down to where the level of bone is. And so if you draw a line across a bunch of teeth, across the CEJs, and you draw another one across where the bone level is, there ought to be about 2 millimeters of difference there before they're going to say that that is actually periodontal disease being present. And so periodontal disease requires that bone loss. Think about that. If you're taking radiographs and you've got your x-ray head like this, but you have it canted just ever so slightly up or down, what's going to happen is that you are foreshortening your x-rays. You're making them kind of squatty. You know, they're not as tall as they would be, and therefore that bone loss is not showing up as clearly as it should be. So suddenly that 2 millimeters of bone loss that you've got turns out looking like 1.7 because the radiograph was a little funny, and then you're not getting your claims paid. Okay, so lesson number one, whoever is taking the radiographs, I would strongly encourage for you to pull out the little rings that are helping you aim. With those rings, you're able to get a nice perpendicular radiograph that's going to maximize that clinical bone loss that's visible on the radiograph when you send that in. I also want to make sure that you're sending in radiographs that demonstrate bone loss in the anterior, if there is some present. And that means they prefer to see a full mouth series, not a panoramic radiograph. An FMX, a full mouth series of radiographs, is going to show that anterior bone loss if it's present. Another thing you could do are the vertical bite wings. There is a code for that, for the vertical bite wings, and those can also demonstrate that anterior bone loss. And so I want you to make sure that you're sending in something like that that's getting a clear picture. On a panoramic, if you're looking at a panoramic radiograph, it's very washed out in the anterior. It's not diagnostic for bone loss. And so it's not a great indicator. Even if you are sending it in with a 4 bite wing set, the whole anterior is kind of washed out. You're not doing yourself any favors, because if there is bone loss in the anterior, that may back up your claim that it is a 4341 instead of a 4342. Bone loss being the primary indicator of periodontal disease, at least the history of periodontal disease. If your patient has had bone loss at some point, that's going to show up on those radiographs. Periodontal disease is forever. Bone loss is forever. It doesn't come back. However, having said that, inflammation is episodic. Active disease is episodic. It can come and go. So your patient can have had periodontal disease that was active at some point. It's been treated. Things are better. The gums are now nice and pink and coral and tight. And so it's not an indicator of active disease process going on. The only time that you have an active periodontal disease happening is when you have inflammation in addition to the bone loss. And so if you've got inflammation, that's going to mean bleeding. So the payers are going to want to see bleeding points in your records. They're going to want to see which teeth have bleeding. Are those sites the sites that are showing bone loss as well? That is an indicator that an active periodontal infection is happening. And that is when a patient could benefit from active periodontal scaling and root planing. So that's the only time. They can have had bone loss in the past, but if their gums are not inflamed, if there's not a presence of bleeding, then that just means they have a history of periodontal disease. They still need periodontal maintenance therapy going forward, but they would not at that time benefit from another scaling and root planing because there's not active inflammation. So those are the two things that we want to make sure that you're really focusing on in your clinical notes and in the records that you're sending to the insurer. You want to make sure that there is a record of the bleeding points, which is the indicator of inflammation, and also that you have radiographically visible periodontal bone loss. And so 2 millimeters, gotta have that. If you're not showing that, what they're going to do is say that the site does not qualify. Okay? If that is the case, if there is not enough bone loss for them to say that they're going to pay for this, they may either deny the quadrant altogether or they may offer you a reimbursement for a D4346. If they don't, you can always ask for the alternate benefit of a D4346 if that periodontal claim is denied. Now, one point I always like to make is that the presence of periodontal disease in the clinical sense, in the clinical opinion of the provider, of the dentist, of the dental hygienist, that's one side of things. The patient can have it and the dentist feels like they could clinically benefit from scaling and root planing. Great, okay? Doesn't necessarily mean that it's going to meet the clinical criteria that is set forth in the plan document of the particular insurance plan. When they pay for things is different than if you have the disease or not. Okay, that's a clear differentiation. And so you can have a certain situation going on, but the plan document language may indicate specifically to what extent do you have to have it before they're going to pay for it. Those are two different things. And so just because you can argue till you're blue in the face that they do have the disease process going on, if it's not meeting all the criteria of the plan document, then they will not pay for that particular procedure. And that's just kind of how it is. Dental insurance is not paid upon whether you have the disease or not. This is a defined benefit plan. There are some guys up in some smoky boardroom somewhere that have made the decision about these are the things that you have to meet in order to get this claim paid. And this is the level that we're going to pay for it at. And so 2 millimeters of bone loss. Let's put that in the contract. And if it doesn't meet that criteria, well, you're not getting paid. Doesn't mean that the patient doesn't necessarily clinically have it. It just means it doesn't meet their criteria for reimbursement. two different things. Next thing I want to talk about is that they have added some new criteria for documentation of services. They now want to see a couple of things that they haven't asked for before. One is the duration of the appointment. So that could be start times and stop times, or just how long you took. Start times and stop times actually is probably preferable. And so that needs to be there. The reason they're asking for that is they had a whole bunch of dentists who were out there that they found that were trying to charge out 2 full quadrants of 4341 in a half hour. Well, we all know that is not enough time to be able to deliver a quality scaling and root planing on a patient effectively. And so for a little while there, they were actually asking for copies of the schedule from certain people. But it is now kind of a criteria that needs to go in your clinical documentation. You need to put your start times and stop times so they can see the duration. They can see that you've taken enough time with that patient to deliver quality care. That's the point and purpose of that. The other thing that they're asking for that they haven't in the past is the types and amounts of anesthesia given. And so that really should have been in the documentation anyway, but they are wanting to see that from the payer side now. Again, reason being, if you think back to the descriptor, it says it requires some soft tissue removal. It requires scaling of the root surface of the tooth, under the gums, root planing. These things are very uncomfortable if your patient is not anesthetized. And so in those circumstances, they're wanting to see the types and amounts of anesthesia given, to note that your patient was numbed. That is a way of them ensuring that you did deliver the code meeting all the criteria of the descriptor of the periodontal scaling and root planing. And so kind of hard to do a lot of that stuff on a patient if that patient is not numb. So that's really the two new things that they've added in. We're wanting to make sure that that's there. So do be sure that you're sending in your full mouth radiographs. They need to be diagnostic quality. Be sure that you're sending in bite wings that were taken very perpendicular. They need to be as flat plane as possible to be able to ensure that you're maximizing the true amount of bone loss that's there in that patient's mouth. It's better, again, to do the comprehensive series than it is to do a panoramic. A panoramic just is not really diagnostic for bone levels, particularly in the anterior of the mouth. Some payers may even reject the claim if the right type of radiographs are not submitted supporting that documentation. Also send in the complete periodontal probing and charting like you've always done. That needs to go with every single claim. That should be the 6-point probing depths, the clinical attachment loss, the bleeding points, furcation involvement, mobility, suppuration, all these things that you've done to stage and grade. All that needs to be there. And they're also wanting to see generally copies of your clinical notes of the date of service. So not so much a narrative anymore that's separately written. They're really wanting to see the actual screenshot of the notes of the date of service. So make sure that your notes are good, they're robust, they've got everything in there that needs to be there. And if you really want to dive off into that, we've got a full article about this that we did for the Insurance Solutions newsletter in November, December of 2024. Full out article that we did on that. And a lot of it was pulled directly from the Dental Documentation with Confidence manual, which is available on our website as well. And so anybody that needs to listen to this, I hope that you would share this podcast with them so that your hygienists are hearing this. The people that are doing the documentation are hearing what they need to do to make sure that it's proper. And hopefully we can get these claims paid. Just be conscious about making sure the bone loss is there, making sure the bleeding is there. Okay. If it's bleeding but not enough bone loss, you're going to be thinking about D4346, scaling in the presence of generalized moderate to severe gingival inflammation. So do make sure that code is on your mind, that it's something that you know how to properly document and identify so that you're treating those gingivitis cases properly. I've got a whole podcast on the D4346 and the D0180. Really, really helpful if you want to dive back in a couple episodes ago and listen to that. That's one of the biggest things we see as a potential increase to bottom line in the hygiene department are incorporating those two codes fully the way that they should be incorporated. And it's been great talking to you guys. I hope that you're walking away with some good stuff, and we'll see you next time on the Dental Code Advisor podcast. Thanks a lot.
This podcast is brought to you by Practice Booster, an eAssist publishing company. To learn more, visit dentalcodeadvisor.com.